Right. Before we begin, we acknowledge that we are gathered on the traditional and unceded territory of the Lummi, Nooksack, Samish, and Semiahmoo people, who have cared for and tended this land since time immemorial. Truth and acknowledgement are critical to building mutual respect and connections across all barriers of heritage and difference. We begin this effort to acknowledge what has been buried by honoring the truth. We pay respect to their elders, past and present. Please take a moment to consider the many legacies of violence, displacement, migration, and settlement that bring us together here today. And please join us in uncovering such truths at any and all public events. Good morning. It is 11:33 on March 11th, 2025. This is the Incarceration Prevention Reduction Task Force Joint Behavioral Health and Legal and Justice Systems Committee. And do you want to kick it off, Dan?
Yeah, so I mean, I can start with what we came up with in terms of work groups and work plan for the Behavioral Health Committee.
Okay.
So what we did earlier this year is or at the last meeting actually, was to try to figure out like who wants to be assigned to what work group. And we came up with three different work groups, and that is reentry/diversion, crisis facilities, which I would rebrand that a little bit. I would talk about Division Street in particular because that's kind of coming up here, and then data. And so those are the three work groups that we discussed, and we have people assigned to each, or who signed up rather, for each one of those. And I can go into that a little bit. I don't know, Raylene, if you want to talk about what work groups that your committee has figured out, or how you want to go forward.
So we have basically the goals and what was provided, and the IPRTF goals and roles and responsibilities. We haven't assigned work groups to certain areas yet, but that needs to happen. On those goals, there are two combinations that came out of the data that was provided to us by our chairs. And there was two that overlapped, and number 3 and number 6 on that graph: strengthen and evaluate diversion programs for justice involved individuals with behavioral health and substance use disorders, focusing on improving outcomes, reducing recidivism, and providing alternatives to incarceration. So that was one of the goals that was overlapped from both legal and justice and behavioral health. And I think since behavioral health and is already working on the reentry, the diversion, and the crisis, really all commingle in that. So to me, it makes sense if we have somebody from legal and justice that could assist in those because they overlap. That would be my suggestion for legal and justice on how we could work on that together. I don't know if anybody has any thoughts on that. The other overlapping is develop systems to improve communication coordination between behavioral health providers working with justice involved clients, ensuring seamless care and integrated delivery, which once again, that reentry factor is both behavioral health and criminal justice, legal and justice. So it seems to me that we need members from legal and justice as well as behavioral health on like a subcommittee, or to group together on that.
Fair enough. Committee members, do you have any input on that? I'm going to expand the screen so I can see everybody. Hey Jill, can you take the there you go. Committee, Bertie, you're muted.
Sorry. What I would say for the data subcommittee, I would also think that those overlap enough that I would recommend we have a joint data sub work group between legal and justice and behavioral health, because we're really addressing the same issues. And I think that would inform the work group very well.
Thanks, Bertie. It's a good idea. Brian?
Yeah, I missed the last meeting, unfortunately. Could you explain the first work group in a little bit more detail? So I'm not sure I completely understood it.
First,
Of behavioral health.
for behavioral health, let me look it up. Reentry diversion. There's a I think it was a 12 or 14 point memo that came out of the task force that identified different areas of focus, and reentry was a part of that, and it got kind of lumped in with diversion. And I can just tell you real quick who signed up for it, and that's Maya, and then Mike Hilly for that one. And so there's a body of work that needs to be done, and I think there's like just such an amount of crossover with legal and justice systems that there might need to be some kind of commingling of those two together.
Those are two very meaty topics in and of themselves.
They're huge. Yep.
Okay, has that 14-point thing been circulated to everybody, or?
I'm gonna have Jill send that out to the group, actually to both groups. It'd be helpful, Jill, if you could do that to both legal and justice and behavioral health, just so we get a sense. We only have a couple people signed up, and so it'd be helpful to get a few more folks on that, and then start to get some subcommittee meetings scheduled, so then they can do their work and then bring it back to these committees in the future. Mike Hilly, go ahead.
I just had a couple quick things. I'd be interested in that first reentry and diversion work group. So Jill, if you could note that. And then following up on what Bertie said, has the executive, if they hired a consultant to do some of to provide some to get this data initiative going, is that happened? I know there was an RFP or something for that, or an RFQ.
Do we have anyone from the executive's office here on the call today? Bertie, do you know? Muted.
Okay, there we go. They have, and it's Village Reach. And I, in my capacity as chair of the index committee, have been working with them. And Julia, the lead person, has posed some really excellent questions. There is a tremendous amount of work that has to be done by us on the task force to complement what she is doing. So I think that the subcommittee would work closely with her, but there is a lot that needs to be done. So it's not conflicting, it's complementing.
And what is the charge of that consultant?
It's available in writing. It's quite a lengthy charge. And it is completed in June. And the basic charge is to develop performance measures for the 15 tasks that were laid out in the implementation plan. And the secondary charge is to do an assessment of our current, ours meaning the county's current IT abilities and what would be needed in order to actually meet the task force. And Melora, you obviously work closely with her and Dean, so if I'm misspeaking, please chime in.
Laura, Dean,
you did great, Bertie. I would, yeah, Dean's hand is up. I'll defer to him. Thanks.
Dean, go ahead.
So I think more particularly the deliverable from the consultant is the development of a performance measurement and evaluation plan. And that, as Bertie's indicated, has really two major components. One is defining measures for how we would, in fact, judge whether we're doing what we want to do and accomplishing what we want. But that has several levels to it. At the systems level, at the program performance level, and at sort of these project levels that are a part of the Justice Project. And then the second part is then, given those measures, are there data available from the various systems that we currently have that can be used to calculate those measures? And if not, what are some of the options for pursuing a more modernized data system or systems?
Okay. Thanks, Dean. Cedric, you've been patient. You've had your hand up for a little bit. Just wanted to call on you.
I guess three thoughts, one new one from that last topic. One, just I second Bertie's recommendation to have more overlap is probably better than less in terms of the subcommittee memberships. Second is if maybe you could just tell us how to sign up for a work group. Do we email you, Dan, or do we email Jill? Or okay, we just can email you, Dan, if we want to join a particular work group.
I would say funnel everything through Jill at this point.
Okay.
And we've got just like the most bare bones membership for each group right now. And it would be helpful to have, maybe 3 or 4 people or whatever the groups decide. But I think, having that minimum of 3 or 4 folks that are interested in these topics to come forward would be helpful. And we've got, just like I said, just a couple. I'll run through it real quick. Reentry diversion is Maya and Mike Hilly. Crisis facilities is Arlene and Danny Carroll, and data is Dean White. And so, we're getting there. We're starting, and I'm assigning myself to those to crisis facilities and reentry. I can just be kind of like not ex officio, but sort of help to try to be helpful. Mike Hilly, go ahead.
Yeah, thanks, Dan.
I had one more.
Yeah,
one
good.
more thing I wanted to say. Just this is more of a not fully formed thought, but it just seems like the data work group in particular will have a lot of relevance to the work that the consultant is doing. So just a comment for that.
Yeah. Sorry, man. I didn't mean to cut you off. Sorry. Go ahead, Mike.
No worries, Dan. Thanks. I won't bail on the committee, I promise, but I do want to qualify that, my diversion interest, experience, etc., is more related on the EMS side. A lot of it crosses over, but for me and Vanya, I think we probably need somebody a little more expertise in the incarceration piece of diversion that we're talking about in that committee. But I won't bail, but just know that a little limited on my skill set for the incarceration side for that. But yeah.
Okay. All right. Just while we're in the moment here, anyone on the call interested in that committee for reentry? All right. Seeing none, we will go ahead. Dr. Wu.
Oh yeah, I needed to check with my family, but I can do the reentry diversion committee, especially I think if we are going to have an involvement from the legal and justice, I think that makes it all the more meaningful.
Okay. All right, Jill, do you got that? All right, she might have stepped away. Okay.
Sorry, I have Brian and Dr. Wu volunteering for reentry and diversion. And Cedric, I'm sorry I didn't catch which one you wanted to be included on.
Oh, I didn't say, but you can.
Okay.
I mean, the data one would be
data.
Great.
Okay, great. Awesome. Thank you.
Great. Amy Hockenberry.
Yeah, I'll be happy to join the data as well.
Thank you. Good. All right. Okay, it's shaping up. Thanks, folks, for stepping up here. Raylene, anything else on your end for the work groups?
I think it would be nice if we could reach out to Caleb and see if there's somebody from the jail that would be able to assist us on some of the data for or the data for reentry and diversion and the impacts that it's having on incarceration. So that's kind of the goal, but we probably should have a representative from there to be able to help. I know they're stretched kind of thin right now, but we might want to check with Caleb.
Okay. All right. I just want to provide some direction here in terms of expectations for the work groups. I think at minimum, what would be helpful is to meet in between now and the next joint meeting, at least once, hopefully more, and get some direction moving forward. And of course, you're always welcome to report to the committee that you're assigned to, whether it's behavioral health or legal and justice systems. But at minimum, I think that we need to come back to our joint session. I think that's coming up in June or somewhere in there. So just to be able to say, hey, look, this is what we've come back with, and to be clear, and Wendy, I'm going to get to you. Just let me finish my thought here real quick. These are recommendations. We're not asking you to go out and like do like boots on the ground kind of stuff. We're asking for recommendations that we can bring back to our committees, and then those committees vet those recommendations. So even if you're not on one of these work groups, we are asking you to think about the work that's being provided through the work groups to then bring that to the task force. Task force brings that to the county council and to the executive's office. And so that's the upstream process, so to speak, or maybe it's downstream. I don't know which direction I'm going here. Wendy, go ahead.
I may be useful for the data group, because that's one of the things I did when I was still the chief. So the other thing I've got is some historical data that goes back for years. And I'll get a hold of Perry and see if, because I'm no longer an employee with the sheriff's office, if there's any special hoops I need to jump through. And I had talked to him about it before I left for a different reason, and I don't think it'll be a problem, but I'll also check with the sheriff. I know Caleb would love to, but I also know that he's kind of overwhelmed right now with some changes that are being made at the jail. So
yeah. No, Wendy, thank you so much. I was hoping you'd step forward. Wendy provides and brings like a tremendous amount of historical data, and she was always the one who would pick up her phone whenever I would call. So I appreciate that. There's a good civil servant there. Deborah, Holly, go ahead.
I can vouch for Wendy always picking up the phone when I called. I would like to be on the diversion and reentry committee.
Okay. Thanks, Deborah. Really appreciate you stepping forward. That's great. This is great. I think we're getting this all together. And are the directions to the work groups? Dr. Wu, before I continue, go ahead.
Oh, I just had two really quick logistical things. To save time for introductions, I would love it if people would rename themselves and write on beside their name where they're coming from. So that will save some time, I think. And also, Raylene, can you give me the names of the two legal and justice committees again?
And Raylene, I think you might be muted.
Sorry, I just wanted to mute myself so you guys could pretend to lip read. You were looking for the two legal and justice committees. The overlap was the diversion program and develop communication coordination between the behavioral health volunteers. So the reentry and diversion with the data is actually an overlap between behavioral health and legal and justice subcommittee. And that is why I think it's important that we bring it together today with the joint, because I think, we need both sides on this. So that's where those things fall in. The one that I didn't bring out here that we have discussed is the restoration and competency. That was also something that was brought up for the legal and justice to review. There is already a subcommittee on restoration and competency. So I think if we can get some more information from that group on where things are standing, but we then again need to look at the data with the jails. So all of that information overlaps between behavioral health and legal and justice. So we really need partners from both sides to jump in on these groups so that we can get accurate information and be able to communicate better, which is one of the goals from the IPRTF that was submitted to all of us.
Thanks, Raylene. Dean White.
Yeah, I just want to make a request. Maybe it's Jill who can do this, but if you could send me email addresses for the folks who have volunteered for the data work group. I don't think I have Amy's new one or Wendy's or Cedric's. And so that'd be very helpful. And I'll be happy to serve as an initial convener for that work group.
Thanks, Dean.
Yeah, once we get a final list together of everyone, we'll definitely get contact information shared. If I can, Dan, we've got, give a quick update on the work group volunteers so far. I have for reentry, again, Brian Estes, Dr. Wu, Hannah Fisk, Alexis Haas, and Maya and Mike Hilly. That's for the reentry and diversion work group. For data, I have Cedric, Amy, Wendy, and
I think Dean was on that list too.
Dean. Yes, is that correct? Have I missed anybody on that? Pardon me?
Oh, Birdie.
Birdie.
Okay.
And then for the crisis facilities, I have Arlene, Danny Carroll, and Hannah Fisk.
Okay. Do we miss anyone?
That's my list. So if I've missed anyone, please let me know.
Okay. Wendy, you've got your hand up. Is that from before, or do you have a new question? No. Okay. All right. No worries. Okay. Well, that's been pretty well fleshed out. And I think that we've covered the overlap components fairly well. All right. So those groups, Dean, you'd offered to be the convener for the data. Is there a convener for the reentry group? Do we have anyone that can just basically call a meeting essentially, and then you all can hash it out? From Brian, Hannah, Alexis, Mike, Hilly, and Maya. Is there anyone that wants to do that?
Dan, Brian Estes, I can do that.
Okay, thanks, Brian. Appreciate it.
Jill, could you send me everybody's email?
Yes.
Thank you.
All right. Wendy, does your hand up still, or no? Okay. All right. I look away because I'm taking notes. I just want to make sure I'm not missing anybody. All right, it's still back up. All right, there you go. Perfect. Nice work. Tori, go ahead.
Yeah, I'm trying to catch up here. The crisis team looks a little light, so maybe Jill, you can add me onto that one. I can help out there.
Thanks, Tori. Okay. Unless there's anything else here, so we're at 11:55, so we're 25 minutes in right now, and we've got a little ways to go. Unless there's anything else with the work groups, it looks like we've got the one thing that we don't have is a convener for the crisis facilities, and I'm happy to do that. I've taken a role with that if that's okay with the folks. So that's Danny, Arlene, Hannah, Tori, and then I would join that committee and just kind of kick things off a little bit. Is that okay with the folks that are there? Okay. All right. Sounds good. And then, all right. So absent anything else with that, is there any other questions or anything that we can clarify? Okay, seeing none. That's actually a good segue into our third item for the agenda, and that's Dijwalik Wellness Center opening at 2030 Division Street. This is the mobile medical units, and so I'm going to give a brief presentation here on what they do and how the process came to be. And there was a ribbon cutting that happened a few weeks ago, and I'm just going to be brief on this, but I want folks to understand this resource in our community. It's a very generous gift that was given to us by the Swinomish tribe. About almost 2 years ago, the Bellingham City Council made public drug use illegal, and largely in response to the fentanyl crisis that has engulfed our communities. And it made the news, made the media, and Bev Keys, who's the executive director of the clinic, and Leon John, who's a 20 years tribal Senate member and their outreach coordinator, reached out to me. And long story short, we went down to the clinic. I went with Chief Mertzig and some other folks from the county to visit the clinic and understand what the work. So it's addiction recovery services, wellness center, dental, medical, NA, AA, the whole thing, childcare. Really an amazing facility, and I hope that we all get to go down there at some point together. And so they then made an offer. They sent an email to me saying, Bev Keys did, their director, saying, hey, we've got these mobile medical units that we want to bring up to Whatcom County. And I panicked and said, thank you, but I've got to talk to my colleagues at the Whatcom County Health Department and our mayor at the time and other colleagues. And we were able to make an agreement. It's a 3-party agreement. The county, Whatcom County, the tribe, and the city of Bellingham are all involved in this process. So they have a mobile medical unit up there and running right now. They build these things up. They're 34 feet long, and they build them from the chassis up. They dispense methadone and Suboxone out of the back. And so they had to be approved by the DEA, and they were, and they've got 1 unit up there right now at Division Street. I just talked with Bev Keys probably about 45 minutes ago to get an update on where things are at in terms of usage. And it's very slow going right now. So there's a lot of outreach that needs to happen to folks that are that have opiate use disorder, whether they're wherever they're staying, Mission, in private homes, if they're at the way station because they've been discharged from the hospital, or if they're in encampments and things like that. And so the real issue, and I'm just going to be frank here, one of the real issues is getting people out to Division Street. So transportation is an issue. We are working, we being one of my colleagues who's on the WTA board, Skip Williams, is working with their executive to figure out ways to make transportation easier for folks to get out there. Currently, there's a bus stop in front of the Ann Deacon Center for Hope. 3 bus routes stop there 13 times each per day. So that's good news. But what we need to do is, in my opinion, figure out if there's a way to get shuttles to go from various places in the community where it would just make sense to pick up people, bring them, get their dosing, get them intaked, and then get their dosing. And if they need further, counseling and things like that, to provide those services. So that's kind of where that's at. There was a ribbon cutting ceremony, I don't know, maybe 3 weeks ago with Nooksack, Lummi, Swinomish, lots of county people, lots of leadership from county and the city. And it was very, very moving ceremony. So that's been kicked off, but we need to get the word out to more people. And so I'm putting this out to the group here today, and I know for your connections, whatever they may be, that we need to get the word that there is this great resource in the community. And we are working with the natural the folks that you would think that we would work with, like the ART, the HOT team, and many other partners. But I want to put that out to the group here today. And I'm happy, and I'll stop there, and I'm happy to answer any questions if you have them. And Melora is probably like 10 times more of a resource than I am on this because she's closer to the work. Pam Jacobs, go ahead.
Yeah, I just want to mention that at the way station, my department has BH services. So we have mental health, and we have people that are doing addiction services as well. So just wanted to let you know that it's not, that there's no availability there. And the way station for us is that, we have the hygiene services there, but we also have co-located medical and BH services. So just to let people know.
Yeah, no, I appreciate that. And I just, before I call him Laura, real quick, I just wanted to say that I think this, if we can look at this as supplemental versus, we're not trying to replace or duplicate anything. We're just trying to, just given the scope of the issue that we have in our community. But Pam, I appreciate you providing those comments. Laura, go ahead.
Yeah, thanks, Dan. I just wanted to add that the Response Systems Division has a transportation specialist. His name is Colin, and he works with over 60 agencies to provide transportation to appointments in Whatcom County. He sends out availability every Monday and he can be scheduled regularly. So if for some reason your agency is not accessing that service, I agree shuttles would be amazing, but we also have someone who does transportation specifically, and there is room right now for people to get rides to the Deeg-Walleach Wellness Center out at Division. I would also say it's been pretty exciting to watch the Deeg-Walleach providers work closely, both with the Work Center Jail that is at Division and Pioneer Human Services and Compass Health, our providers at the Ann Deacon Center for Hope, to make sure that if someone there is needing those types of services, they can coordinate directly, and they're just a 1-minute walk away. So it's been, I'd say, exciting to see the idea of a behavioral health campus take another step in that direction. So thanks for the update, Dan.
Thanks, Laura. And I think that's one of the purposes of this time together here today, is to kind of share that information, remind each other that we do have these resources out there in the community, and it's important to collaborate versus duplicate. Dr. Wu, go ahead.
So this is kind of a nitty-gritty question, but I see on the website it says clinic hours are Monday to Friday, 6 a.m. to 3 p.m. and 6 to 3 on Saturday, but MOUD dosing is 8 to 12 Monday through Friday and Saturday. So is the MOUD dosing hours, is that specifically methadone, or is that also when Suboxone is prescribed, or are they not? Well, anyway, so I just need those details.
Laura, do you want to take that one?
Yeah, so the mobile medical units that are dosing with methadone are only there during those hours because it has to go back to Anacortes every day, the mobile medical units. It's a good question, and Hannah, I don't know if you know if the other MAT services would be provided during those other hours. That's a good question. I would assume that the mobile medical units are only doing methadone, and that other medications could be received in the clinic during the other hours. But we can get to the bottom of that and let you know, Dr. Wu.
Thank you.
Okay. Any other questions? Hey, Captain Larson, just while I got you on the call here, is just through your work with community paramedicine and the GRACE program, I know you both ride together, is getting the word out about this resource, is that something you guys have done or can do, or do you have any opinion on that?
Yeah, it's definitely just in passing to my coworkers as a resource. It doesn't have a huge place in the emergency medicine side of things, but in my world and my partner's worlds here, yeah, I think it's a great tool that we have now, and just another tool to have to get our clients in. And yeah, if they're one of our clients, we absolutely will transport them up there ourselves. In terms of trying to wrap my brain around in terms of advertising this, I don't have a quick answer for you, but no, I'm on the same page and ecstatic that we have this resource here in town as another tool.
All right. Thanks, Captain. Melora, go ahead.
Yeah, I would just add that Leon John from Deagwall Leach has been doing ride-alongs with all of the different local teams here in town and kind of building, because they are a new provider to Whatcom County, even though we have had Whatcom County residents going down to Skagit. They are a new provider. So Leon's doing a really good job of just building that relationship. I know he has developed some flyers that he's been distributing. We've been highlighting this in our outreach team meeting, our behavioral health provider meeting that happens every 2 months, our GRACE meeting that happens every 2 weeks with providers. So there's lots of venues and we're just continuing to get that information out. I have asked for something that we could circulate online, and I haven't received that yet, but I will ask again and see if that could be circulated with this group.
Thanks, Laura. Deborah?
What about a press release?
We have done a press release and there was quite a bit of coverage with the ribbon cutting. Both Bellingham Herald and Cascadia Weekly covered it.
Okay, great, thanks.
Arlene, go ahead.
Is this located in the work center? Yeah.
Arlene, it's located in the old detox and crisis triage space, the clinical side on the west side of that building.
Yeah.
So right across the parking lot from the Ann Deacon Center for Hope, and then it's in the same building as the work center, but right, different entrances.
Mike Hilly?
Yeah, thanks. I was gonna say we might be able to help with that a little bit through our Narcan Leave at Home programs. And so that's a bag that's about this tall, this wide. We have information we drop in that. We're actually working up a similar thing with the hospital to advertise their buprenorphine program. So as you hand that bag out with the Narcan, I'm hoping that we could add a little flyer for the mobile medical clinic in there so that people, if they're looking for a referral, because we drop the other MAT providers cards in that thing too. So I'm not sure who would be doing that work. If it's already there, print it up and send it over to me, and we'll start stuffing bags. If not, maybe Swinomish or something might design that little flyer, whatever it might go out in it. And then we can send it to all the fire departments. What I do know is sometimes even in the rural fire department, somebody will knock on the front door and, hey, how do I get help? Well, this is great for the firefighters way out on the end that have something to hand to somebody that they can actually recite to and talk to people with, because I mean, may not be informed about the requirements or how to get there, where it's at, etc. So,
Laura, is that something that you can, or someone from the staff can work on, or how does that work?
yeah, sorry, Laura, I didn't mean to do that to you. If there was something already printed that we could put in there, it'd be great, or even replicate. But
yeah,
for us, it needs to fit that little bag. So
yes, we are working on it already. So Ashley Smith is our GRACE supervisor, and she oversees our new pilot behavioral health specialist that is doing follow-up for folks at risk of overdose and survivors of overdose. And so she's been working closely with Bellingham Fire and with Mike to make sure that that information can be added to that. So I think that's already in the works, and hoping that Gordon, who is that person who can do follow-up after post-overdose, would get referrals from EMS crews. They could get referrals from the hospital. They've already gotten quite a few referrals from the jail, and we've been able to get people released to go straight to treatment. We've already had 3 people successfully do that. So really, some really good, exciting work in that realm.
Yeah, Dr. Wu? Oh, I think you're still muted.
There we go. This is just one additional resource. I just found out via Chuckanut connections that that the Cascade Medical Advantage has received a supply of long-acting injectable buprenorphine. Sublocade is the brand name, from a grant that they can administer to people who are uninsured, underinsured, or have Medicaid, which is nice because it's otherwise very expensive.
Thanks for that update. Thanks, Dr. Wu. Appreciate that. All right. So anything else on this topic? Okay, I don't see anything. Let me just check the other page real quick. Looks like we're good. Okay, so the next item is monthly overdose stats, and that report is from Mike Hilly. from Wacom EMS.
Yeah, thanks, Dan. Let me bring this up real quick. That big enough for everybody? Let me
Can you zoom that out a little bit so it's bigger?
let me see if it'll zoom up here. There you go. Better?
Yeah, it's still pretty small on my screen, but I don't know. Can folks see that all right? Yeah.
And I
Okay.
did send a copy in the package. I think that's as large as I can get it on my screen. Sorry
Okay.
about that.
Nah, well, that's fine. We'll make it work.
Okay. Yeah, this is just a quick snapshot. I did update this slide today that included the weekend, but the first slide is just a look back for to 22, and you can, I think we saw this data before with just the monthly data, and this was our peak month in May of 24, and then this we saw it kind of going down, and all the way into March right there. So that's look backwards. We are, it's trending down a little bit. And then here's our daily call volume, and this is all the way up to the 8th of March over the weekend. So this is the stuff that occurred basically from February to March. We're averaging at that 3.0 ODs per day. And actually, just keep in mind, these are EMS responses only. It's not necessarily everything that's going on out there. And then, of course, the blue and the green are separate from opioid versus usually multi-drug or meth or something like that. So, and that's identified after the fact by toxicology. So this is just another way of looking at it throughout the year over year previously. And just you see, once again, 23 and 24 were those big years, and kind of get to 25, and it seems to be settling down a little bit. And then it's a look at our naloxone distribution. And yeah, I do apologize. I don't know why this couldn't be a little bit bigger. But this is kind of what we're seeing going out for naloxone. And so this is calls, just general opioid calls in those given years, and calls where Narcan were used, and that's by the provider itself. This section here is Narcan that was given prior to EMS arrival, or what's known as PTA. And actually, over the years, you saw, I would like to say it's probably representative of how much Narcan was going out between 2020 and 24 now. And that number is representative mostly civilian responders, although law enforcement may have given that prior to arrival as well. And then here's a mix of EMS administered versus prior to arrival. And this is kind of interesting right here. And as I've heard a couple of fire chiefs comment here in the last year or so, that the people out, the first responders, the civilian first responders, are now giving out more Narcan than actual EMS providers are on call. So I thought it was an interesting comment to see that. And this is just another way to look at these overdose responses, year over year trends, and then patient dispositions, what happened to those patients after the hospital. And you can see unsuccessful resuscitations or dead on arrival here. This represents that non-transport. This is interesting because earlier in the year, I'd been reporting the non-transport rate at almost 42 to 45% was the highest. But we're seeing people willing to accept transport a little bit more at this lower 35%. And this is going to be interesting to watch as well. This is one of the reasons that the hospital wants to do BUP education, because we'd like to be able to measure that once the word is out and everybody realizes that there's a life-saving drug at the emergency department called buprenorphine, will more people be agree to transport to the hospital? And personally, I just think that's a large part of the narrative that goes out there when the EMTs and paramedics are talking with the patients they're seeing, that in the last really 4 months, we've had a lot of big changes in the system that maybe would change that narrative. Mobile medical, MOUD, and the emergency department, EMS will be offering that in the street soon. So this is, we want to watch this close and see if this is going to change. And then this is just a different look at the patient profiles over the last years, and by gender and age profile as they stream across. And of course, our biggest demographics in that 30 to 39, but I'm always interested in this one out here, 70 to 79, and even in that 80 range. And I ask a lot of questions about the medication errors, medication, not getting track of it, or not getting the medication you want and going to something else. I think it's interesting, that number up in that older age range. And this is updated. My Diana Clinch, our data analyst, updated this, and this is a snapshot of where all these calls that generally happen. This is coded by EMS. You know, what the location is also picked up on the initial dispatch, but many of these are in the single family homes, or many are housed. We do have a sliver. Here's our unhoused population here, and in other public places where we have the ODs, and really the apartment and the single family home we kind of lump together because they're housed under a single roof generally, and so that really gets connected to this more. But then many are out on the highways and are out in fields or in their cars, etc. So this is a good snapshot of where these calls are happening. And then this is just the most recent dashboard off the WhatcomOverdosePrevention.org. This is just another way to look at the volume. And while I don't have a way to sort of lay EMS calls over this, I can tell you that the ED visits are very similar in how these rates go out. So if you look in here, well, let's look at our May day. Here's our May right there of 24, the highest we had. So emergency department had 84 visits over that 61 from the previous year. So, and I was showing 160, I think it was 158 overdoses in that same time period for EMS. So it's interesting that the ED saw maybe 64 of those that came in that day, that month. Once again, Whatcom County overdose related deaths for between 22 and 24. Not my data, hard for me to analyze on, but definitely a good peek at the death rate here in the county, as reported to the health department. And then another way of looking overdose deaths by the demographics, once again, these age ranges, and this is consistent with the types of overdoses you saw in this slide from EMS too. And then here's some sources for it. Whatcom Overdose, this is where if you want to look at the EMS data, this is updated daily. And then WhatcomOverdosePrevention.org on that. And I think that's about all I got for that. I hope that's a good update for you guys. One thing I will send out to you, Dan, I think I sent it earlier, and it's a lengthy document. I mean, it's like a 30-page document if you want to share, but that's also the Washington State OD Death Surveillance Bulletin that comes out of the King County Medical Examiner's Office. And it's a really, as soon as I get off here, I'll send it if you want to distribute out, Jill. And I didn't include it here because it's just too long, but it's a really good snapshot of what's going on in the region. And these are all the deaths that happen up and down the I-5 corridor with competing or counties that contribute to that data. So I'll send that over for distribution. Very interesting to look at. You can see the types of overdoses that are going on, types of drug paraphernalia being used, places where the drugs were used, and some photos of some of the scenes that are out there. So, but anyway, I'll send that. If you get any questions, go ahead.
Thanks, Mike. Hey, Pam, go ahead.
Yeah, I've been invited to do a presentation on opioid use for the mayor's outlying of Bellingham. And I wanted to know, Mike, if you had any access to data like urban versus rural, kind of the, cities of like Linden and Everson. They're asking for information about how they can be helpful. I imagine most of the activity is in the Bellingham area just because of population. But if there's any relevant information that would be good to share with these smaller cities, I would love to have that, to give that to them.
Yes, absolutely. We this is the very condensed version, but my data analyst Diana Clinch is really dialed into this, and yeah, we can really break down a lot of specific information. I've got a map of every OD in the county and a dot where those happened. And then we also can part down by zip code. But I'd be willing to, if you want to come over and spend some time and kind of let us know what you want to do. And then I would encourage you to reach out to Chris Hughes over at the Bellingham Fire Department as well. He's their data analyst. And Chris Hughes, I think, probably has a very good look at his local stuff that's going on right in Bellingham that I know his council members and leadership like to look at too. But we're glad to help. Glad to partner, and we can give you a good systems view look. So,
okay, thanks very much, Mike. I might be in contact with you offline or just through email.
Absolutely, yeah. Thanks.
Thank you.
Brian, go ahead.
I just had a practical question because I do carry like Narcan when I'm driving around, but I have to admit I'm kind of reluctant to administer it without knowing kind of what's involved. I mean, I was thinking maybe I would call 911 and they could guide me through it or something, or they would send somebody. But are there any training videos or any resources available to what you consider when you should or should not, engage somebody and attempt to resuscitate them?
Yeah, we have pushed out a few videos through social media, just some stock stuff. However, here in the county, my colleague Steve Cohen, training specialist, has pushed out. In fact, he just had a Narcan training event last week. I think there were about 30 people in that event. And that's exactly what he does. He kind of ties in a little bit of information about Narcan, how to deliver it, and then a little bit of first aid that goes with it, right? Because we encourage agitation on the chest, get the drug moving around, and we also encourage the limiting of the doses a little bit because we're seeing way too much Narcan go out on certain patients. But yeah, we offer a 2-hour course, and then we can push some stuff back up on social media too that we got to just remind people on that. But if you're interested or others interested in a class, give me a call and we'll figure out when the next one scheduled is for you.
Thanks, Mike.
Yeah. And Steve,
Melora?
I saw your head. Yeah, I assumed you wanted to comment. I'm
Oh
sorry.
yeah,
Dan.
yeah. Sorry, Steve. Go ahead. You had your hand up for a minute.
Yeah, just to reiterate, Chris Hughes does have a bunch of data for overdoses within the city. So if you're looking for that, that would be a good resource.
Thanks, Steve. Laura?
Yeah, Brian, I just also want you to be aware that the WhatComeOverdosePrevention.org website actually has videos on how to administer Narcan, what it is. Just so, I think your reluctance makes a lot of sense, and a lot of people feel that way. And so it is something that, when you learn how to use it, you realize that you can't really do much harm. So that's another resource. And yeah.
That was whatcomeprevention.org.
It's WhatComeOverdosePrevention.org, and the dashboards that Mike Hilly just showed are also on that website.
Thanks, Laura. Okay. Anything else pursuant to that item, Dr. Wu? Go ahead.
Yeah, I'm really glad people asked that question because I noticed in the state data that there's one page where it says Narcan administered as a fraction of situations where EMS was called out, where Narcan was available on the site but hadn't been administered. And it looks like it's roughly half. So half of the time, someone's called for an overdose and they have Narcan, but they actually haven't administered it. So I think there's definitely a window for improvement there. I will just point out that, YouTube tells you what to do. And there's some the first ones that pop up on YouTube are very credible. There's one from, Mass General and Brigham and Women's Hospital in Boston. So there's, it's not for lack of information. But I think reassuring people that it really is safe to do is probably the main step. And this might be something for us to look at. The other question I noticed in the state data that I wanted to ask is, Whatcom County's not represented in that state data. And I'm wondering why that is. I don't think it's because we have too few cases. It looks like they're only cooperating, they only have participation from some health departments. And I'm wondering why we're not part of that.
Yeah, Dr. Wu, I can grab that, Dan. So the program's run it's called the Coverdell Grant, and that's what King County ME uses to do all that work. The contributions that are somewhat voluntary. I haven't met our new medical examiner yet and hadn't had a chance to talk to him, but the prior medical examiner did participate in that program, and that participation was somewhat I won't say ordered, but strongly encouraged by our county council about 4 years ago to participate in that because we did have some high numbers in there. So at the moment, my understanding is I know we're not participating because on the last report, which I'll send you, we're not even listed as a contributor anymore per previous reports. Like I said, I just haven't had a talk with the ME to understand if he knows about it or if he's not doing it for any reason, etc. And then you're right, Dr. Wu, if it is below a certain threshold number, that they won't show that county for that month, but you're still listed as a contributor. So that's usually a cue that you've been under that amount for that reporting. So, but that's what I know about our current situation with the ME and the reporting.
Yeah. Any other questions for Mr. Hilly? Okay, seeing none. Thanks, Mike, for that presentation. It's always good to get the updates on that, just so we can kind of track where we're at. So I appreciate that. That takes us to our next item, which is other business. And that's anything that the group wants to bring up to put on a future agenda, or something that we missed today that people want to talk about. And so this is your opportunity to contribute for that, if you have anything. Brian, go ahead.
This is related to a document that SAMHSA put out some time ago on best practices for homelessness and mental health or mental illness. And it's a pretty beefy document. I don't know if the committee really would want to take that on, but I'd be willing to kind of condense it. And I just thought I'd throw that out as a topic, perhaps for a future meeting.
Brian, can you send that to Stephen Gockley, myself, and Jill? And if Raylene wants to take a look at that, that would be just,
Okay.
just so the chairs can have just.
And I'll probably also do an AI. AI can do it like a 4-page summary or something, because it's like 100 pages. So,
okay.
But well, just as a note, one thing I thought found interesting, I used to get emails from SAMHSA quite frequently, and they've stopped. So that's interesting.
Okay. I'm not going to read into the political implications of that.
Yeah.
Okay. I hear what you're saying. All right. Okay. Thanks, Brian. Yeah, if you can just maybe send that more condensed version, that'd be helpful. Cedric?
Well, maybe this is too political, but I've been wondering what, if any, impacts service providers or even the county or the cities have experienced as a result of some of these federal executive orders. I know it's a big topic and also ever changing, so the answer today might be different in a month or two when we next meet to talk, when this next gets on an agenda, but it would be worthwhile to know the status of any funding, and maybe to the extent possible, of look into the decision making. What decisions are being made out of an abundance of caution versus, like, we were told directly this funding would be stopped, or you would be, debarred from Medicaid if you kept doing this. So I would be very interested in that.
Okay. Thanks, Cedric. I can give you a very quick Cliff Notes answer to that from the city council, or from my perspective as a city council member. So I brought that very same question up yesterday during open session, in terms of what are the impacts on any cuts to Medicaid, and how would they impact any Bellingham residents that are receiving that benefit, and also as it relates to housing and subsidized housing, either through the HUD program or CDBG, which is Community Development Block Grant. And what are the impacts? And at this point, it's kind of unclear. It's still fairly early, but I do think, all politics aside, we do need to understand what the impacts will be for the folks that we're trying to help, basically. So I think that might be a topic for a future meeting, like maybe in the next, short term here, Q1, Q2. Well, we're going to be in Q2 right now, but I think that's maybe we look at that and try to have a more fully developed understanding of what the long-term implications would be. And I hope that's not like a politician's answer to your question, but that's what I got for you so far.
No, it's good. I mean, that's where we're at. And I appreciate it.
Okay. Thanks, Cedric. Thanks for bringing it up. It's real. It's absolutely real. So, any other items for other business today? Okay. I don't see any. So, we might be able to get you out of here a half an hour ahead of schedule. We do have one last item, and that is public comment. I noticed there's a few people in the attendee room. Jill, do you want to handle that?
Yeah, we do have a number of attendees virtually. If you want to speak to the committees, please virtually raise your hand right now. And I don't see any hands raised.
Okay, thanks for doing that, Jill. Appreciate it. Okay, anything else for the good of the order today? Okay, we were scheduled to go till 1. It's now 12:32, so we gave you 28 minutes of your life back. So have a good rest of your day. Thanks as always for attending. Thanks Legal and Justice for all the work that you're doing, and we'll see everyone soon. Take care.